Good afternoon, everyone, and thank you for having me here today. I think, not that I think, I know that I've learned more from you than I think you'll be learning from me. I'm always interested in talking about end-of-life issues, not only from my own personal experience, but from the work that I do at Maimonides. And I'm always concerned that the simple act of talking, not the content of the talk, but the simple act of talking about life-threatening illnesses, end-of-life care, our fears, the goals the goals we want at the end of our life, our desires, our belief system, have in my mind become very politically incorrect. And to me, that's very sad. Two major transitions that all of us go through are birth and death, and yet we celebrate birth and we have shut off most of the communications that we have and the opportunities we have to talk about how do I want to die, how do my loved ones want to die. We even have a hard time speaking to our loved ones, our friends. And from a clinical perspective, if we can't speak to our loved ones and friends, we certainly have a hard time speaking to our patients when life-threatening illness has been diagnosed or people are diagnosed with terminal illness. Just to give you a little bit of a context of how I got to working with these issues is I'm a psychiatric nurse by background. I got interested in health law and how the law affected everything we do in healthcare, so I went to law school at night. I got interested in bioethics, so I was educated in that as well. So I've kind of put together a career that spans the clinical, the ethical, the administrative, and the law. And I wanted to talk a little bit about psychiatry. I think my background in mental health really has given me an understanding that the issues we're talking about today are the use of self. And in psychiatry, your main tool is yourself. And in medicine, I think we have forgotten that we're very good at providing the medicine, the technology, but we have gotten away from what we call in healthcare the soft side, the caring part, the understanding about people's lives, suffering, the context in which they have lived their life, and the context in which they're living through their illnesses. Relationships, and I think that's what we're talking about today, is that we need to develop more relationships that are open and with our patients, with their clergy, with the communities that we're involved with. And you're so right, Pam Breyer brings the community into the hospital, and we bring the hospital to the community. So how do we, when I started to think about the talk today and the context of this conference, it did bring me back to the law. And I thought this was a very interesting issue in New York State. Why did we have to pass two laws, the palliative care access law and the palliative care information law? Why did we have to pass laws to help people talk about illness, talk about diagnosis, talk about symptom management, talk about options available? We had to make it a legal issue rather than a clinical issue, and I find that relatively sad. The two laws, they talk about appropriate care for patients. And I struggle every day when I meet with families and patients, and many times when we're talking about end-of-life issues, the patient is not able to participate. And so the families become our patients as well, and maybe even our primary patients. And who decides what's appropriate for this patient? That's the struggle between medicine, science, religion, beliefs, is who defines appropriate. The National Consensus Project for Quality Palliative Care defines palliative care, and I thought it would be good to share the definition, because I think we all have different ideas about what palliative care is about. And I've gotten involved through my bioethics work with our palliative care team, and it is definitely interdisciplinary. And it brings a wide variety of understanding about patients and the human condition to that clinical team and to the patient. So palliative care is defined as patient and family-centered care. And from some of the audience this morning, it doesn't sound like we're meeting that entirely, that it's not entirely patient-centered. That optimizes the quality of life. Again, who defines quality of life? I'll give you a personal experience. My father is dead well over 35 years, long before laws got involved in end-of-life care. And my father wanted a guarantee that the care provided to him would cure everything. Well, that guarantee is not available then, and it's certainly not available today. So he chose to have nothing done except to provide for his comfort. And my family, my mother, my sister, myself, other relatives, we fought with him. You can't do that. You have to be able, you have to take the care that's available to you. Well, eventually, because it was pretty quick by the time he died, we were understanding that this was his choice. And he died a very quick and peaceful death. My mother, on the other hand, wanted everything done. And when we get to talking about everything, what does that mean? And how does one define it? How do the clinicians define it? How does the family define it? How does the patient define it? And we often find we're on a different page to understand what it means to do everything. Well, my mother wanted everything done. She drew her line up here. My father drew his line down there. But I was older now. My mother's gone only a few years, and I had much more experience. So I had a great opportunity to talk with her about what she wanted. And though it might not be what I would want, but it was what she wanted. So my mother lived on a ventilator and with a peg for 5 years, coming home part-time and being in a nursing home part-time and her family caring for her. And yet when she reached that level, we were able to provide the removal, the withdrawal of the ventilator particularly. And my sister and I were in bed with her, and she died in our arms. A gift. That was the greatest gift I think I've ever gotten in my life, to be there when my mother died now. I bring all of that to my work every day. And so, optimizing the quality of life, we need to talk to each other about it. What does it mean? Preventing and treating suffering, that's another question. Who defines suffering? For some, I worked with lots of families. For some families, suffering is part of the end. And suffering gets you closer to whomever your God is or that other being is. So who defines suffering? And that's a challenge. The healthcare professionals see suffering in one way, and families and patients often see it in a different way. And there's a continuum to the illness. How do we address the physical, the intellectual, the emotional, social, and spiritual needs, and to help facilitate patient autonomy and choice? How do we facilitate that? It sounds easy. It's probably the most difficult thing we do in healthcare, is how to understand what people, patients, families want in the context of how they live their life and in the context of how they want to die. Again, it's interdisciplinary. Patients, families, interdisciplinary physicians, nurses, social workers, chaplains, all come into how we handle not only healthcare, end-of-life issues, but chronic, progressive, and life-threatening illnesses. And I'm going to go through some of what I studies, and you've heard some of this earlier. Studies have shown that the majority of patients with advanced illnesses have high information needs. We're also healthcare professionals. We're not good at we're good at sharing information, We're not good at sharing it in a language that people understand. And so I can think I'm the greatest communicator in the world. When I talk about communication, I speak many languages. I speak Brooklynese as my first language. So I have to translate that when I'm writing into English. But I also speak legalese, I speak medical jargon, I speak regulatory jargon, and I'm not sure that anybody can understand that unless we have a conversation. And I ask you about what we've talked about so that I can have an understanding about what you understand. So palliative care is to prevent and ease suffering and improve quality of life. It provides support to patients and caregivers. It improves communication. It identifies and addresses choices that are available. It helps coordinate care. It provides emotional support. It identifies goals of care, not only from the patient and family's perspective, but from the clinical team's perspective. And it addresses patients' wishes. How do we know what we want unless we talk about it? So some of the symptoms that palliative care addresses, many illnesses, breathing difficulties. How do we address that short of putting people on respirators and ventilators? How do we address the pain? The woman in the back talked about pain and pain management and the myths of pain management and the belief systems we have. Many illnesses create fatigue. Constipation is a big issue. Loss of appetite, sleep. Treatments that we provide, the healthcare professionals provide, often have many side effects. How do we deal with the side effects of the curative aspects of healthcare versus the support aspects? And we should be focusing on what patients and families want. I was thinking a little bit about what, if I had my wish would be that I work in a hospital, so I see patients in the hospital setting where they're very close to the end of life. If we could bring the clergy in to help to see those patients and to work absolutely in the healthcare setting with families, with the clinical team, understanding what the patients are going through when they're on ventilators, when they're on dialysis, when they have intractable fevers, when they have infections that no matter what kind of antibiotics we give, the infections are still there. How do we put that together that creates a plan that is sensitive to the wishes, desires, beliefs of the patient and the family, and addresses the issues of when care can no longer be curative or beneficial, and when care sometimes becomes harmful in nature. So thank you.